So
today we have a case discussion on a patient with a young male patient with the anterior mediastinal mass. During evaluation, I also saw the features of myasthenia gravis. I'm Dr. Moyes, surgical oncology, thoracic, resident here at UTMCS. So our patient is a 34-year-old male from Virgans who is a shop owner by profession, who presented with the chief complaints of dysphagia for what since 2 years, with increasing and waxing and waning type of episodes. There are episodes of improving of eyelids since 7 months, episodes of dysphagia after 7 months, and upper limb weakness for 7 months. So, as a clinical lineage, our patient is a 34-year-old male present with episodes of dysphagia since 2 years, with new onset ptosis, dysphagia, and upper limb weakness progressive in nature for about 7 weeks. On examination, patient has well-healed physique, stable vitals, and also a gradual developing ptosis and dysphagia was noted during the interview. No weakness of limbs were noted. No other systemic abnormalities detected. Patient had received treatment at multiple centers with suspected of Horner syndrome, but with no significant improvement. He was suspected with myasthenia gravis in Lucknow and was started with pyridostigmide 30 mg TDS in Kathmandu with partial improvement in symptoms. His CT scan during evaluation revealed anterior mediastinal mass. He is a known hypertensive since 1 year under medication and has been referred to our center for further evaluation and management. He occasionally uses alcohol and smokes tobacco. CT scan of the patient revealed 9.3 by 6.2 into 3.73 centimeter of anterior mediastinal mass, with a few coarse calcification noted within, and the heterogeneous enhancement noted in the post-contrast state. Severity, it was abutting superior vena cava with lots of happening at places. Posteriorly, it is also abutting right atrium, right ventricle. Anteromedially, the lesion is abutting the right inframammary vessels. Laterally, the lesion is abutting and compressing anterior segment of right upper lobe and middle segment of right middle lobe. Small heterogeneously enhancing lymph node were also noted, measuring 11 into 9 mm noted in the right hyoid region. So here we can see the diagram images. We can see the lesion being shown here in the right part of the right side of the mediastinum, anterior to the great vessels. See the enlarging part of the tumor while going distal from cranial to caudal. So the lesion can be seen in close proximity with the heart. Alpha-fetoprotein was done, which was normal. Beta-HCG was also normal. All the lab investigations were normal. ECG was normal. Hormone test was also normal. The patient has not undergone any form of biopsy, and he has been planned for that's anterior mediastinal mass. Now, before going to management, I would like to discuss briefly about myasthenia gravis and the current guideline and what do they say. So, starting with the background and history, it was in 1644. Marsteller first described the symptoms of myasthenia gravis. Clinical syndrome was identified by Wilkes, Herb, and Goldblatt in 1895. The efficacy of 5-6-stigmine was shown by Walker in 1934, and in 1941, Harvey Marsland accurately localized the pathologic locus of myasthenia gravis to be the neuromuscular junction. They also described the structure of the neuromuscular junction and how the pathology started. Blalock and colleagues and later Keynes described transsternal Thymic in myasthenia gravis, including a complete removal of the gland as possible, whether or not the tumor was suspected. And this happened in the same year as Harvey and Marsland and described the pathologic locus of myasthenia gravis to be the neuromuscular junction. So in 1960, an autoimmune cause of myasthenia gravis was suspected by Simpsons and Nasser chemicals. So to give an overview of the neuromuscular junction and acetylcholine pathway, the image here shows a diagrammatic representation of how neuromuscular junction is made. So a neuron with its presynaptic nerve terminals form a neuromotor inflect with the muscle fiber. We can see the neuron endings with being attached very close to the muscle. So here we can see when we zoom in to the neuromuscular junction, we can see the nerve terminal, presynaptic nerve terminal, having vesicles of filled with acetylcholine, which are released upon the receiving of axon nerve action potential, which results in the releasing of the acetylcholine vesicle into the synaptic cleft, and these acetylcholine are then received by the acetylcholine receptors, which are ligand-gated ion channels, which are formed of 5 subunits: 2 alpha unit, 1 beta, 1 delta, and 1 either epsilon or gamma. So gamma is present in denervated neuromuscular junctions or fetal or neonatal muscle implants, and epsilon is usually found in the adult. So this structure has a 2.65 nanometer length with a 0.65 nanometer width in the narrowest part, which is less than sodium ion. So the acetylcholine is gets attached to the site between the alpha and delta subunit, in which there is the receptor. Also, the alpha has got the receptor site for acetylcholine receptor antibodies that are formed in the response to the altered alpha subunit protein due to genetic changes. So this figure here shows an electron micrographic image, which shows the nerve terminal, also surrounded by the Schwann cell, and the processes of the muscle membrane that in which the acetylcholine receptor reside here. So this cleft is only about 50 nanometer width, and after the receiving of the action potential in the nerve terminal, the acetylcholine vesicles are released in this cleft, and the acetylcholine get attached to the receptor cell. So here we can see the fluorescent in situ hybridization image, in which the green is green structure symbolizes the neurofilament with the alpha bungarotoxin, which gets attached to the acetylcholine receptor. So it stands as the red. You can see the red as the acetylcholine receptors and the green as the nerve terminal. So here we can see another picture, which was during the study of the myasthenia gravis in experimental animal models. So this of the mice model, which was experimentally induced myasthenia gravis. So in these mice, these are the images taken before myasthenia gravis. We can see the well-formed food processes like structure here in the muscle membrane, which get flattened and reduced in number after the experimental induction of the myasthenia gravis was done in these mice. So this also resulted in reduction of the acetylcholine receptor numbers as well. So the autoimmune pathogenesis was originally given by being the thymus gland being the origin of the myasthenia gravis was hypothesized initially by Weigert in 1901, and loss of self-tolerance was the concept that was introduced. The thymus contained all elements for activation of acetylcholine receptor specific T cells, which include an immunogenic peptide of the acetylcholine receptor or a peptide that mimics the receptor, which might be due to the alteration in the gene sequence, which was responsible for production of the normal alpha subunit of the acetylcholine receptors. So a local antigen presenting cells, usually a myeloid cell in the thymus, and a class 2 molecule of major histocomplex which initially takes up the acetylcholine receptors and present it to the CD4 T cell, helper T cell, which activates the AChR specific beta cell B cell activation, resulting in the formation of the antibodies, which induce the complement system reduction, resulting in the destruction of the acetylcholine receptors. So the main sequence is the antibody-mediated process, which results in reduction of the postsynaptic membrane AChR. So multiple mechanisms are noted. One is the receptor degradation by the complement system. Another is endocytosis of the receptors and flattening of the postsynaptic membrane, resulting in reduction of the surface area as well as reduction of the AChR number. So how do we diagnose it? Initially, all the patients do undergo history and physical examination as every patient that we develop. So Osserman and Jenkins initially classified the myasthenia gravis clinically. So the Roman letter 1, 2A, 2B, 3, 4, and 5 are of the Osserman and Jenkins, and the MGFA 1, 2, 3, 4, 5 are the myasthenia gravis Federation of America, Foundation of America, Association from this is a US foundation studying the myasthenia gravis. So how do they classify? The class 1 in both the classification are include the ocular form, which in which the patient shows ptosis and diplopia. In class 2, there is a mild generalized form and the faciopharyngeal form, in which mild generalized weakness and bulbar weakness are noted. In class 3, in the classical Osserman classification, severe acute generalized form is present, in which the patient has acute severe general weakness with bulbar symptom and respiratory insufficiency. And in MGFA class 3, the medium severity generalized form is noted, in which the 3A include patient with involvement of extremities more than faciopharyngeal muscle, while in 3B, faciopharyngeal or respiratory musculature is involved more often than extremity. In class 4, it is a severe chronic generalized form in Osserman classification, while in MGFA 4, it is a severe generalized form in which A and B are categorized. A means extremities are more involved, and B means faciopharyngeal and respiratory muscle are more involved. While in class 5, myasthenia with a severe residual deficit is present, and forms of muscle atrophy is also present in Osserman classification, while MGFA 5 classify as severe myasthenia gravis requiring intubation. So other evaluation are all the patients with myasthenia gravis are to undergo CT of the mediastinum so as to rule out any thymic mass or malignancies. PET CT can also be used, and these are FDG AV lesions. And any lesion that are any myasthenia gravis associated with the FDG AV PET lesion are usually considered to have a good prognosis after surgery. And it is never considered a good idea from a pre-surgical biopsy because of the risk of myasthenia exacerbation. Or in some condition where patient is being planned for neoadjuvant treatment, then we might go for pre-surgical biopsy with the caution of avoiding myasthenic crisis. So another other physiologic evaluation are the electrophysiologic evaluation. One is the repetitive motor nerve stimulation. Yeah. We can see a pictorial picture, which in which multiple in which the nerve is stimulated multiple times in a second, and we can see the amplitude is quite consistent in the normal, but it decreases in the myasthenic patients. Another is the single fiber electromyography, which is considered more sensitive as compared to repetitive motor nerve stimulation. And here we see the jitteriness of the response, in which normal jitter means 10 to 50 milliseconds of differences in the two stimulation, while there is increased jitteriness in case of myasthenic patients. Another is the antibodies to acetylcholine receptors, and these are very important investigations during evaluation of the patients. So there are 4 assays that we can see. 3 are the acetylcholine receptor antibodies, and 1 is the MuSK receptor antibodies. So acetylcholine receptor antibodies can be found 3 types.
binding type. These are the first to evaluate and usually present in about 90% of the cases. Other two are the blocking and modulating type. And most receptor antibodies are present in about 30 to 50% of the AChR negative cases. And altogether, we might deal with about 12 to 17% of the seronegative myasthenic patients. Now, coming to treatment, I'll just give initially a theoretical background of what are the treatment options and their general information. So, acetylcholinesterase inhibitors, usually the pyridostigmine that's used, is given 60 milligram 4 hourly, as if we see in the literature, while the patient is weight increasing to about 120 to 180 milligram until undesirable side effects are noted. So the dose has been increasing in the recent guidelines. Corticosteroids can be used. The prednisone is the most commonly used corticosteroid, usually starting with 50 to 20 milligram daily, increasing by 5 milligram every 2 to 3 days to a maximum of 50 to 60 milligram daily, followed by alternate day dosing. And the recent guideline, the British guideline, says daily dosing is better as compared with alternate day dosing. So azathioprine are considered for patients who exhibit poor responsiveness, intolerance, or frequent relapse with receiving corticosteroids, and also in patients who seems unsuitable for thymic and patients with thymoma. The dose is considered as 50 milligram per day starting to maintenance level of 2 to 3 milligram per kg per day with careful monitoring of liver function, peripheral white blood cell count, and platelet counts. There are three basic drawbacks to its use. One is the idiosyncratic side effect. About 10% patient can be seen with these side effects. Another is bone marrow suppression, which occurs in all the patients, and a long delay in onset of therapeutic effect, about 3 to 6 months or more. Another is cyclosporine. It inhibits the T-cell dependent antibody responses by reversibly suppressing the clonal expansion of the activated helper T cell. It also inhibits inflammatory interleukin 2. And administration can prevent an expression of the induction of the experimental myasthenic gravis. Long-term use is associated with dose-dependent and cumulative nephrotoxicity owing to endothelial vascular injury and interstitial fibrosis, hypertension, and fatigue. Mycophenolate mofetil, initially used for organ recipients for immunosuppression. It is an inhibitor of urine synthesis and who may be considered a poor candidate for corticosteroid or intolerant to azathioprine might go for this option. Usually a useful long-term parenteral therapy to induce improvement, especially in the severe thymomatous and non-thymomatous cases. Rituximab is another recommended medication that is a monoclonal antibody against B-cell. It may be appropriate in treatment refractory patients and also with patients with muscular autoantibodies. Another option is the plasma exchange and intravenous immunoglobulin. So plasma exchange drastically reduces the amount of acetylcholine receptor antibodies and helps in managing acute condition and myasthenic crisis. So another option is the human immunoglobulin, which is a non-specific immunoglobulin that can be used for clearing up of other type of autoimmune conditions as well. So these two modalities are usually reserved for managing acute conditions. So, so how IVIG works is it inhibits the specific idiotype to anti-idiotype antibody interaction, downregulates the autoantibody production, and inhibits the binding of acetylcholine receptor to the acetylcholine receptor antibody. And drawback include high cost in both options. PE requires specialized equipment and staff, potential shift of body and fluid and electrolyte imbalances, and need for indwelling catheter for vascular access, while IVIG can be associated with flu-like symptoms, aseptic meningitis, renal failure, headache, hypertension, anaphylaxis, especially in the IgA deficient patients, and a small risk of transmissible disease as it is made by donation of the different hundreds and thousands of patients. Now coming to thymectomy, the technical goal of the surgery is to remove complete all the tissues of the thymus gland, and total thymectomy can be a difficult condition as total thymectomy can be a difficult thing to achieve because the gland consists of multiple lobes in the neck and mediastinum. And as per authors of Seals, transsternal thymectomy with exploration of the neck and mediastinum for thymic tissue should be performed for patients suspected of thymoma in order to prolong survival, prevent tumor recurrence, and induce remission or asymptomatic status. Usually, patients with intermediate and highly malignant well-developed thymic carcinoma should be treated with postoperative irradiation, followed carefully with chest CT for signs of recurrence. And patients with exacerbation of myasthenia suspected of having microscopic tumor recurrence should be watched carefully for detectable tumor relapse, at which point chemotherapy and pre-operation may be necessary. Now, coming to consensus guideline, I could access only this consensus guideline given by Myasthenia Gravis Foundation Association in 2020, and newer guideline is from British Association given in 2025. So I will just list out the recommendations as per the guidelines. For thymectomy, in non-thymomatous patient with a generalized myasthenia gravis with ACSR antibody positive status, aged 18 to 50 years, thymectomy should be considered early in the disease to improve the outcome. And it should be strongly considered in patients with ACSR positive generalized myasthenia gravis patient if they fail to respond to an initial adequate trial of immunotherapy or have intolerable side effect from that therapy. It is an elective procedure and should be performed in patients when they are stable and deemed safe to undergo the procedure, where post-operative pain and mechanical factors limit respiratory function. And these complications can result in myasthenic crisis as well. Endoscopic or robotic approaches to thymectomy are increasingly performed and have a good track record. But based on comparison studies across the globe, less invasive thymectomy approach appears to yield similar result to more aggressive results. But we have to counsel the patient that minimally invasive approach may not always result in the same outcome as open approach. So thymectomy may be considered in patients with generalized myasthenia gravis without detectable ACSR antibody if they fail to respond adequately to immunosuppressive therapy or to minimize intolerable adverse effect of the immunosuppressive therapy. Also, the current evidence doesn't give any support to indicate thymectomy in patients with MuSK antibodies, low density lipoprotein receptor related protein 4 or for ocular myasthenia gravis, ophthalmoparesis or ptosis in ocular myasthenia gravis that is not responding to anticholinesterase agent should be treated with immunosuppressant if symptoms are functionally limiting or troublesome. Corticosteroids should be used as initial immunosuppressant, and steroid-sparing immunosuppressants may be treated with corticosteroid alone are ineffective or contraindicated or not tolerated. Small RCT suggests that low-dose corticosteroid may be effective in ocular myasthenia gravis, may avoid side effects associated with high-dose corticosteroids, and those with ACSR positive patients with ocular myasthenia gravis do not respond adequately to acetylcholinesterase, or who either prefer not to take immunosuppressive therapy or have contraindication or are refractory to IS may be offered thymectomy. Another is recommendation regarding rituximab. It should be considered as an early therapeutic option in patients with MuSK antibody positivity who have unsatisfactory response to initial immunotherapy. And efficacy of the rituximab is uncertain and is an option if patients fail or do not tolerate other immunosuppressive agents. Regarding methotrexate, evidences from RCT are lacking, while may be considered as a steroid-sparing agent in patients with generalized myasthenia gravis who have not tolerated or responded to steroid-sparing agents. Another is the eculizumab may be considered in treatment of severe refractory antibody-positive generalized myasthenia gravis. The role has been considered to evolve over time, and cost also has some role in its use. Recommendation of the Advisory Committee on Immunization Practices and other local guidelines regarding immunization against meningococcal meningitis should be followed before treatment with eculizumab. So future research should include assessment of the duration of eculizumab therapy necessary to achieve and maintain treatment goal, its efficacy in other myasthenia gravis patients with thymoma and seronegative myasthenia gravis and other stages of the disease. Regarding role of immune checkpoint inhibitors, the risk of myasthenic gravis and other immune-mediated neurological illness should be discussed with patients who are candidates for ICIs. At this time, there is no evidence to either support or refute the utility of ACLs and antibody testing in patients without MG before starting ICI. Early aggressive treatment with a high-dose steroid is in combination with exchange or IVIG, plasma exchange or IVIG may be required in patients who develop overt MG with the use of ICRs. So there are specific drugs that we need to avoid and use with caution during myasthenic gravis. So one of the aminoglycoside antibiotics, beta blocker, botulinum toxin, chloroquine, and hydroxychloroquine, corticosteroids. These, even though they are considered as a part of treatment, first 2 weeks can be critical in the patient as this can result in deterioration of the patient. Desferrixamine, penicillamine, fluoroquinolone antibiotics, immune checkpoint inhibitors, hydrogenated radiologic contrast agents, macrolide antibiotics, magnesium, procainamide, quinine, statins, and telithromycin, and live attenuated vaccines. These are to be used with caution or avoided if possible. So now coming to other treatment guidelines. First, let's just talk briefly regarding the WHO classification of thymoma, which has classified in 5 different classes: type A, type AB, B1, B2, and B3. These are in type A, thymic epithelial tumor with light spindle and oval, rarely polygonal epithelial cells are present. So staging has also been given in the TNM 9th edition as T for primary tumor, considering tumor less than 5 cm to be T1A and more than 5 cm in T1B, with T2 indicating direct invasion of the pericardium, either partial or full thickness, or the lungs or the phrenic nerve. T3 with direct invasion in brachiocephalic vein, supervena cava, chest wall, extra pericardial pulmonary arteries of vein. T4 with direct invasion into aorta, arch vessels, intrapericardial pulmonary artery of veins, myocardium, trachea, strikes. With N1 means involvement of anterior perithymic lymph nodes, and N2 with deep intrathoracic or cervical lymph nodes. M1 is distant metastasis. Now coming to staging, Masaka staging was given, and also the HSCC staging 9th edition can stage disease accordingly. Now coming to what NCCN guidelines is. So this is from the version 2026 given in April 2026. So any patient with mediastinal mass, we initially evaluate the patient, and if a thymic tumor is likely present or unlikely, we might treat them accordingly. If the thymic tumor is not suspected, a tissue diagnosis is considered. For thymic tumor, who are surgically resectable patients, we go for surgical resection initially with complete excision of the tumor, and who are deemed to have locally advanced or metastatic disease, we consider for tissue diagnosis and then treat accordingly. For patient with artery resection, for thymoma or thymic carcinoma and no capsule invasion with stage 1 Masarka-Koga. For thymic carcinoma, we go for surveillance with a CT scan every 6 to 12 months for 2 years, and then annually for 5 years. For thymoma, CT scan for every 6 to 12 months for 2 years, then annually until 10 years. For thymic carcinoma with a capsule invasion present, we go for post-operative radiation therapy. For iron resection also, we go for post-operative radiotherapy, and if the patient is having thymic carcinoma, we might consider chemotherapy as well. And for R2 resection, we go for definitive RT and chemotherapy. So all patients should be treated by the multidisciplinary team with experience in the management of thymoma and thymic carcinoma. And also we have to evaluate the patient for any symptoms of myasthenic gravis and paraneoplastic syndrome. For locally advanced cases which are unresectable, we go for concurrent chemoradiation, and which are potentially resectable, we go for systemic therapy. Then reevaluate if resectable, we go for resection and consider post-operative RT. For if the patient is unresectable, then we go for definitive RT and chemotherapy. For resectable, we go for surgery and similar treatment. And for medically inoperable or unresectable disease, we go for systemic therapy or consider local therapy or consider observation. For extra thoracic metastasis, we go for systemic therapy. So these are the principles of surgical resection. Fundamentally, we go for complete removal of the tissue. Debulking of the tumor is discouraged. So these are the principles of radiation therapy. A dose of 60 to 66 gray are given to the patient with unresectable disease. For adjuvant treatment, 45 to 50 gray for clear or closed margin, and 54 for microscopical positive resection. Total dose of 60 to 66 gray given to patient with R plus resection. So coming to systemic therapy, first line conventional therapy, chemotherapy regimens are cyclophosphamide, doxorubicin, and cisplatin, and there are other recommendations as well. For thymic carcinoma, carboplatin paclitaxel with or without ramucirumab. So these are other subsequent therapies. Thank you.
Thank you, Dr. Mai. So can we go back to the CT scan? Now coming to your our case. So we have to decide what to do with our case. Well, incidentally, I mean not incidentally, he went with a problem of dysphagia since last 2 years, we said, and later on he was thought to have the myasthenia gravis. What tests would you recommend? You didn't mention that was confirmed by any test or not. It was just on the clinical background, right?
Yes.
And he improved on the treatment. So if that kind of patient comes to you, what kind of diagnostic test would you suggest to the patient?
Yes, first we will go for imaging investigations as well. For imaging investigation, the patient as has undergone CT scan, we will advise a CT scan of the chest, abdomen, and pelvis as well, also including the neck. So we will look for any anteromediastinal mass. In our patient, we have found anteromediastinal mass in close proximity to heart and blood vessels. Apart from investigation, imaging investigation, we have an option of FDG PET scan if possible, and can help in identifying presence of thymoma or carcinoma.
So in such case, you found that there is the mass in the anterior mediastinum. Can you show in the CT scan? What are the radiological criteria?
Yes, here CT can be seen here. You can see after the arching of the aorta, we can see the image, the like small part of the tissue, which grows as we go caudally. So
My first question, how would you differentiate the thymoma with the lymphoma? Yes. Just so this, you think this is lymphoma. I will say that it's lymphoma. I will say that it's not lymphoma on the basis of CT film. Not mediastinal lymphoma. The lymphoma general is not huge, solitary. This will give many multiple stations of the lymph node. It's quite unusual to see a single such a big lesion that will represent the lymphoma. In such a big tumor, there should be many other lesions as well. So hello.
Any other tumor that may mimic the features of myasthenia gravis?
myasthenia gravis.
Just the myasthenia gravis, other tumors are
In small cell lung cancer,
Lambert syndrome.
Lambert syndrome.
About you, so you said this is not the. How will you difference that? I would say this is not the germ cell tumor. Radiological point of view.
Radiologically,
Generally, the germ cell tumor might have some calcification, some other structures, kind of bony density. Then it could be that it may be the germ cell tumor. So in such case, is it must that surgeon? Is it must that you will advise for some tumor markers? If you see any intermediate mass, so what kind of tumor? Pardon? Why? To say that this is germ cell tumor or not, functional germ cell tumor or not. And he said only AFP and beta Hc. Would you add something else? If you are suspecting the germ cell tumor? tumor marker match, he said that it is FP beta is only. Is it enough? You must incorporate the LDS also. LDS also, because there is the classification which incorporate both three factors in the classification concept. So now you said that he has got the features of myasthenia gravis. So what test would you recommend to the patient to confirm it? You think that please again slide, but just summarizing, you can just short them.
So one thing we can do is
Just 1, 2, 3, 4, 1 again.
first we can go for ethopodium test.
Yeah, we can go for
We can
it.
go for that.
Just for the audience, can you
Or
say what is
other
that?
other serological tests like ACSR antibody can be seen.
Antibodies to ACSR
antibodies.
receptor is must. Because you said in 90% of cases they are seropositive. So we must see whether it's positive or not. Right? It's this one.
So if
At the same time, would you suggest some more antibodies to be seen?
mask antibody can be considered.
Mask antibodies have also to be seen. The negative positive seropositive and seronegative. In the seropositive group, we have three parts. In the last sentence, you said about the lipoprotein 4, but in the beginning, you have to say this is the seropositive, seronegative. Seropositive means ACSR is antibodies positive, anti-mask positive, and lipoprotein 4 positive. In the seronegative, seronegative. So you said two parts of describers. Next test, you said about the EMG, that's very good.
Repetitive nerve stimulation.
So you have test 7. Now, in our patient, he has come with ptosis in the context of myasthenia gravis. Which part of the muscle is first involved?
Usually, the first muscle to be involved is ocular muscle.
Why?
Because
That is the muscle that is frequently used. Even blinking once because the superior palpebral, elevated superior palpebral. So even have biceps along, triceps along, but whenever the patient see, he's always blinking. So this is the superior palpebral elevator. That is the most important muscle. So quite frequently often involves. That's why it's involved. So therefore we classify broadly. If you don't go to the Wasserman classification or MG, your myasthenia gravis task force association of America classification, then we say this is either ocular or the generalized myasthenia gravis. So this is the muscle. What's the next second muscle which is involved? It's all the ocular muscles and facial muscles. One is for abduction, therefore the patient presents with the diplopia. These are the common findings. The next common muscles, the proximal skeletal muscles. And then only the last comes the respiratory muscles like diaphragm, etc. when the patient will land up in the ventilator. Okay. Especially stage migration. Now, you said that he has got both the tumor and the myasthenia gravis, right? So how would you control the myasthenia? Would you take the patient suddenly for the surgery?
No, we cannot take the patient for upfront surgery unless we have got all the myasthenic symptoms.
And this is a very important message. Last slide, my myasthenia thymectomy should never be considered an emergency surgery. Message clear thing. It should be elective. Patient should be stabilized well with the myasthenia. Great. So what will be the drug of choice in the beginning that you will start with?
So we have to consider the first drug that is always given is the pyridostigma.
To available in a palpebral in never those in the one cell. Now again you can add the steroids. So steroids have to be added only for a short time. एउटा स्लाइडमा तिमीले भनेको थियो there is a contraindication, though it is said that immunotherapy, immune checkpoint inhibitor is also beneficial in the thymic carcinoma and also in the thymoma. But you have mentioned in one of the slides it is contraindicated in the case of thymoma with myasthenia gravis. Why?
Because when a patient there are increased chances of infection or
It's one thing. The next thing will myasthenia gravis, the autoimmune disease. And the immune checkpoint inhibitor will provoke the autoimmune disease.
Yes.
So in that part, the patient will have the myriad of symptoms which is the myasthenia. So therefore, myasthenia gravis ma even immune checkpoint inhibitor दिइन्छ. तर एउटा contraindication कारण चाहिँ त्यो हैन र
त्यसमा हाम्रो इम्युन चेकपोइन्ट इन्हिबिटर काम हुन्छ त्यसै गरी त्यो इम्युन अफ गरेर
Hydrophonium test obsolete was.
Absolutely. So the classical technical things and the absolute by the source of order that is the interferon test.
Preoperatively, post-operatively pulmonary crisis also.
But now, so they are not
Intraoperative
one.
Intraoperative Peterson.
त्यहाँसम्म पुगौ होला one of the questionमा फेरि मैले रिपिट गरौँला. So now, how often do you see the myasthenia gravis in a context of thymo?
Patients with thymoma about
30%.
हाइटमा भएकोलाई कति पर्सेन्टमा मायास्थेनिया ग्राभिस हुन्छ र मायास्थेनिया भएको ग्राभिसलाई कति पर्सेन्टमा थाहा हुन्छ?
35% of patients with thymoma present with the myasthenia gravis and about
15 to 20% myasthenia gravis has got thymo. Now let me tell you one thing. You said that there are certain you have to stabilize them. Coming to his point. So you are the anesthetist. Now he has advice for the surgery. What are the indications for surgery for myasthenia gravis? You said, for the audience, can we revise it? When you will consider thymectomy in non-thymomatous myasthenia? There is no tumor, but he has got the myasthenia gravis. Tell me the points when you will consider for the surgery.
When the patient has got
Seropositive. With
seropositive status, with decreased responsiveness of the immunosuppressive treatment that he has been receiving, one, or another is to reduce the dose of
which seropositive?
ACSR.
ACCR and anti-mass lipoprotein you don't consider. So or seronegative you don't consider. This is one point. Right? Then what's about the age? In your slide, there is certain age criteria when you will consider for the surgery.
18 to 50 years.
Till 50 years. Beyond that, 50 to 60 years borderline, patient might have a response to the surgery, may not have this. If somebody is beyond 60 years, you should consider it, because those patients will not be benefited from surgery. Hamro kesma kesa the patient has got thymoma, tumor with myasthenia gravis. So do you think that this patient should be considered for surgery or not?
But indicating, we have to also rule out if the patient is MuSK positive.
Anyway, doesn't matter. Tumor ka cha ni?
So we
Tumor
can,
cha bhane anyway surgery, whether it's MuSK or non-MuSK, it's non-thymomatous now. If there is a tumor, anyway the patient should undergo surgery, right? Our surgery you are the anesthetist, surgery is the anesthetist. The patient comes to you. What precautions will you take? Has it?
so we have to avoid muscle centrally acting depolarizing neuromuscular relaxation, depolarizing agent, because when we use the depolarizing agent, it self block the acetylcholine receptors.
So what would be the best option for the surgeon? Then the anesthetist said that there is a high risk. The patient may get into the ventilator for a long time. So what would be the best approach for you then?
Best approach would be inhalation on anesthesia.
Inhalation, avoid the muscle relaxation.
Muscles.
So how good is it for, how easy is it for you, for surgeons? The best way for the myasthenia gravis is just give the inhalation non-intubated. Do not give the muscle relaxation. You can do the epidural, local, regional block, then proceed for the surgery. That would be the best option for the surgery. Another this was what are the intraoperative precautions that you would use? When you extra solve the there you go. The was a mirror approach. If this patient is tumor sanos, you give the surgery. You give the intercostal blocks or epidural anesthesia without any muscle relaxation. Take the patient for the surgery. Now we are considering the surgery. A patient, what approach would you use? You have said various approaches: sternotomy, thoracotomy, videostasis surgery. Give us. Looking at the size of the tumor.
Size, we would consider for a transitional approach.
So the best approach will be the sternotomy, right? Why?
One thing is it gives a good exposure of the mediastinum, and we can also extend the incision so as to explore the neck as well.
What is the cons of the sternotomy?
We might not be able to expose
The inferior
part
the
of
lower
the
parts are not very visible to the midline sternotomy. But this was the lower smooth marginal side diaphragmatic nerves, the diaphragm of the tongue, that of the sternotomy. They said, what is the difference? Would you take out only the tumor or do something else? There is a concept of radical thymectomy or focal thymectomy versus simply partial thymectomy, means taking out the tumor. What approach will you use?
we have to remove all the fibrofatty tissue around the tumor as well. Also, we have to check if any part of the extent.
Then it's a where is the general localization of the thymic tissue? So because she has got the myasthenia gravis. If no myasthenia gravis, may not make any difference whether to do the radical thymectomy or do the partial to take out the tumor. But when there is the myasthenia gravis, you have to take out whole thymic tissue. Then means from phrenic nerve to phrenic nerve, from the thyroid thymic nerve to the diaphragm. यो सबै इन्कर्पोरेट सबै टिस्युहरू चाहिँ निकाल्नुपर्छ अनि बल्ल त्यो सर्जरी कम्प्लिट हुन्छ. What do you think about the lymph node dissection? Is the lymph node dissection important or not?
If thymic carcinoma is suspected,
कार्सिनोमातिर जाँदैन. यो हाम्रो केस. Simple logic. TNM classification भने यतिकै त लेखेन होला. Therefore, lymph node dissection has to be done. Lymph node stations are different though. Don't need to go for the level 9, level 8 as per the lung cancer classification. They have divided in two groups, N1 groups and N2. What's the difference?
N1 means perithymic node.
Just anterior, just superficial lymph node, and N2
means the deeper
lymph nodes, generally located where?
In the
paratracheal region, aortopulmonary ligament region, and it's lower cervical supraclavicular जहाँ फोसा हुन्छ त्यही ठाउँमा नै थाइमस हुन्छ इनियरको लोअर paratracheal bilateral aortopulmonary region त्यसमा जनरली हुन्छ subclavian lymph node and supraclavian lymph node. These are the regional stations for the carrying very broad borders. हैन यति कुरा हामीले बुझ्न पर्छ थाइमोमा. केही अरू छ साथीहरुले सोध्नु?
थाइमो यो सर्जरी गरिसकेपछि पेशेन्टलाई को चाहिँ सिम्पटमहरु रिलिफ हुन्छ त?
About 50% only patient will have a continued remission of the symptom.
अनि यो पाइरोडिक स्ट्रिप कन्टिन्यू गरिराख्ने कसरी?
Continue.
सिम्पटम टेपर गर्दै अनि लास्ट गर्छ.
Very confusing. Why the patient having the Horner syndrome? It is quite common myasthenia gravis thymol to be associated with the Horner syndrome.
Patient was misdiagnosed with the Horner syndrome. Maybe
he doesn't have Horner.
Doesn't have.
I think. Did you look into his eyes?
Yes.
Did he have the meiosis?
Yes, right side.
Constricted, sir. People skin. I don't think he has got meiosis. Generally, it was confused. Generally, ptosis is bilateral. Sometimes it may happen unilateral. So, description of Horner syndrome along with the thyma has been described very rarely. So, you can totally explain. But I asked him, well, people ma derin, so, in a hydrosis is not there. Now his eyes are bigger and people may have no person because meiosis is there. Ptosis, meiosis in hydrosis and not enophthalmos. So chart of features are on scope. So he has got ptosis, he has got the enophthalmos, but I don't know about the in hydrosis he doesn't have. And you people know constriction my thoughts and everything. Dr. Zhang, would you like to say anything?
Oh.
Tomorrow we are taking this, not tomorrow, after some days we are taking this patient for surgery. So do you want to comment?
The MG is for the we must know the MG lifelong disease. Continued treatment is needed. Surgery is only a part of it. The follow-up drug control is very important. In China, in Hebei province, China, the chairman of MJ community, he is a MJ patient. After the surgery, who has been under good control for 20 years. So I think the patient after the surgery, the drug control is very important.
It's a
Sir, book sir. University point has used.
Oh, you the full. So neostigm is the intravenous drug. It's not available, so it's not used generally. Generally, it is most of the crisis.
Emergency condition.
Then you have the option. So you're a good one. You may discuss what is the difference between the cholinergic crisis and the myasthenic crisis. And there are two different things. You have been using the higher dose of the pyrogenic patient may land up in the cholinergic crisis. Is not well controlled, then that is the myasthenia crisis. Myasthenia crisis is our time constraint look at therefore you test or your neostigm is not really available. Let's say by the period of so sort of only poisoning. So cholinergic crisis or say poisoning. So yes, let's say myasthenia crisis system. Honestly, एउटा point very important गरेको थियो yet Lambert's so it was how would you differentiate? You say when जान जरुरी एउटा concept के भने चाहिँ myasthenia gravis patient repeated गर्दै गयो movement भने he can हैन by the end of the evening morning जागरुक हुन्छ evening मा चाहिँ एकदम ठिक हुन्छ but yet Lambert Eaton syndrome opposite हुन्छ हैन उसको मर्निङमा फिट हुन्छ काम गर्दै जाँदा झन् जागरुक भएर जान्छ त्यो एउटा डिफरेन्स छ ठिकै छ यसलाई क्लोज गरौँ थ्यांक यू भेरी मच लाइक
Or yes, sir.
so तिमी के भन्नु